Okay, good morning, good afternoon, good evening, good day. Happy Lunar New Year. For those of you that are Bengals fans, this is the year of the Tiger. So good luck on April 13th, or sorry, February 13th. My name is Jerry Dickerson, and I am moderating today's session. At the end of the session, I will provide you both in the chat room and verbally the CEU code. Before we get started, please remember to mute yourself. Questions can be asked using the chat feature. The presenters have said you could put in there to raise your hand and we will attempt to stop and answer your questions. And I don't think I have anything else to include, so I'll turn it over to Sally and Grace. Take it away.
All right, thank you so much, Jerry, for the introduction. Just to introduce myself, my name's Sally Taylor. I'm a physical therapist at the Shirley Ryan Ability Lab and had the privilege to serve as our manager of our complex wheelchair seating center for a number of years and have recently transitioned into an associate director position at Shirley Ryan. And this area still reports up through me. And with me, I'll let Grace introduce herself.
Hi, my name is Grace. I was the business support manager for the Wheelchair Seating Center for several years. So I actually had the opportunity to actually kind of guide the wheelchair center through the changes that we're going to be describing here today. So kind of getting a little taste of it beforehand and kind of seeing all of the results and everything of the afterwards, which is extremely exciting. But we're excited to share our results with you here.
Great, thank you. For those of you who are on the line, we want to ensure this is as engaging as possible in the Zoom format. So if you want to feel free to use the chat feature or just use any of the icons to raise your hand, we'll be happy to pause and be able to answer your question at that point in time as well. So thanks for, I know at the end of the day presentation, we always like to say a shout out, everybody's thinking about dinner and happy hours. So thank you for spending some time with us today. So we wanted to just, as you guys have all seen the title of our presentation, this was really a quality improvement project to improve the service that was being provided to our patients that pass through our complex wheelchair and seating center. And before we get too far into the details, we also wanted to acknowledge a member of our team, Dave Brewington, who is a research analyst here and has really worked in the quality improvement department. And we also just want to recognize all of the staff members and the patients that participated in some capacity, as well as the suppliers throughout this project and other key stakeholders that you'll identify. So just so everybody kind of has a scope of what we'll get through today is really to highlight how quality improvement projects can be impactful in the hospital environment. And we're going to focus specifically the key topic today as it relates to patients who may require a wheelchair. And then we're going to go through the key stakeholders, what their role is and the process, and then really talk through how, if you're on a member of a management team and you have your own clinic, how might you be able to really optimize any of the resources that you have to improve any of the aspects of your wheelchair ordering process. So we do have no conflicts of interest to disclose. I already kind of recognized a number of the key players and acknowledgement. And then we just want to clarify that we did go through IRB approval for some of the retrospective chart audits that were completed for our data collection throughout this project. All right, so I'm going to let Grace kind of kick us off with a little bit of the background of just the seating center in general.
So with the Wheelchair Seating Center, we're actually centralized because I know some particular hospitals actually kind of disperse this throughout some of the other job roles. But our particular department here, again, we kind of receive the patient referrals and also the physician referrals who decide that a patient might be appropriate for a wheelchair, and then kind of guide the process along the whole way. So kind of being that advocate for the patient, advocate for the physician, and then also again, kind of that collaborative working partnership with the suppliers who actually build and manufacture the wheelchair, and then also critically being an advocate again for that patient and making sure that everything is as transparent as possible with the processes, what's taking all the processes, the documentation and everything that's required for the wheelchair process, because as a patient, they may not know that there's a lot of the back end that needs to occur. So again, our particular department was kind of making sure all of this was happening and happening smoothly. So in regards to the clinical teams that we worked with, we had both the inpatient and the outpatient clinical therapy team here at Shirley Ryan Ability Lab. And then we also have as well our outpatient day rehab, which is a little bit more intensive outpatient clinical. So kind of from all areas of patient care, we were working with those clinical teams. And then again, also we have specifically physical therapists and occupational therapists who are trained in wheelchair and seating and positioning techniques and experience. So that's the team that's here housed within the wheelchair seating center. And then also critically, again, we have our physician team. So thankfully we have a great number of physicians here who have experience with wheelchairs, and we're being able to collaborate with them and make sure that we're receiving all the referrals of patients who need to have the wheelchair. And then also, like I mentioned earlier, we collaborate with a lot of the durable medical equipment vendors and suppliers who actually manufacture and build the wheelchair. And again, also we collaborate with the patient family, and then finally also care managers and social workers as they get involved as well.
Thank you. So just to make sure we're all on the same page, and this is not new information to you, but we always just want to clarify in any presentation. So for the scope of this project, we did separate durable medical equipment, which would be just like a basic rental wheelchair, any transfer devices, mechanical lifts, hospital beds, commodes, and any type of shower equipment. That was not the scope of this quality improvement project. So we specifically were focusing on the complex rehab equipment, and that would include any custom manual wheelchairs or power wheelchairs. So that was able to help us to really delineate the clarity of who we were trying to reach and make an impact for the equipment being ordered. And so Grace kind of did an overview of the department, and we just like to reinforce why we as an organization kind of made sure of all of these different components for the patient is because, you know, as you guys all realize, ordering any complex equipment is a very complicated process with the insurance and guidelines and mobility devices. From an inpatient perspective, the patient physically wouldn't be able to leave the building if they don't get a wheelchair, and that has to be coordinated from the outside equipment companies. You know, we want to make sure paperwork's not lost. You know, insurance companies have specific deadlines to get people to leave the building. And so, you know, we really kind of owned it within our department that the more efficient that we could be at going through all these checks and balances, the more we could help facilitate the process for discharge for our patients, as well as help them to ensure that they have the appropriate equipment for that themselves. So this kind of goes in a little bit more in detail. So, you know, the physician, obviously there's the requirement of the mobility device visit. You know, they're describing what the patient needs. You know, then the clinicians, either the specialty OT or PTs, are doing the thorough evaluation alongside the assistive technology professionals from the various suppliers, and then a letter of medical necessity is written. And then we need to send that to the outside equipment supplier, and then hopefully the insurance approves the wheelchair, and then the vendor builds the wheelchair, and then the patient eventually comes back to the complex seating center for the definitive fitting of the chair, and just to make sure that everything that was spec'd out in the order is appropriate for the patient. So that now that you guys have a little bit of a scope, I just want to pause. Any questions at this point in time? I know this follows a lot of similarities of other complex seating centers that exist across the country, but just wanted to see if there's any other questions at this point before we kind of take a deeper dive. All right, we'll go ahead and continue. So our quality improvement project was sparked by myself taking a new role in the organization in 2017. I actually was asked to be the manager of the Complex Seating Center. Simultaneously at that point in time, we were moving from the old RIC facility and into our new current facility and renamed as the Shirley Ryan Ability Lab. And during that process of onboarding to the new role, it came to light in conversations that I was having with the director over this area, as well as various team members and some feedback from some patients and nurses, that they had some frustrations and concerns regarding the timeline that it was taking for a patient to actually get their definitive equipment approved and delivered. So with that, we kind of started taking a little bit of a deeper dive into how could we potentially improve this process for our patients, what could be involved in that, and really starting to analyze the workflows that were taking place surrounding the actual process from beginning of the evaluation to the delivery. And this next section, we're going to go into quite a bit more in detail on the specifics of how we did that. For those of you guys who've been familiar with like the Plan, Do, Check, Act process, we followed that in a semi-structured way because we did, work with our quality department. Obviously, when you're catering something to a specific area, we weren't necessarily having a, formal withholding or, like testing of things. We were basically analyzing the processes as existed and then seeing how we could modify them to streamline and then improve them. So our ultimate goal was really to evaluate the change, a change, if there could be one, in a time frame from when the delivery of the definitive wheelchair occurred based on when the patient was seen for an evaluation. And as we mentioned in the very beginning, we ended up doing a retrospective chart audit. So everything that we're going to be describing here in this section of the things that were changed, that all took place from when we started in 2017 and started kind of analyzing the workflow of the department. And then we used that IRB to do a retrospective chart audit of patients that were seen prior to that time. So as we kind of move forward with the specifics, it's I wanted to just kind of plant that seed for how we ended up getting more of that baseline in the spirit of a formal quality improvement project. So here's just kind of a summary of some of the things that we did. And I know Grace mentioned some of the key players as we were talking. We'll go in a little bit more detail of all of those, but really we asked the question, what are the roles of all of those key players? There was never like a clear guideline of who did what. There was duplication of workflows. There was kind of a misnomer. Maybe somebody thought someone else was doing something. And we kind of needed to kind of take a deeper dive into that. The second major thing is that we undertook a major information systems project. For those of you, I don't know, maybe a show of hands, how many people have ever done an IS project with their EMR? So we were actually on the Cerner platform, and that was quite an involved process of getting the IS department approval, going through and making some of those modifications. And so we're gonna talk, and we'll share some screens about how we streamline the physician referrals, the clinician scheduling, documentation of the mobility device visit and the physician notes, as well as adopting existing frameworks for the physician certification that existed in other levels of care that had never been operationalized for the seating center to ensure regulatory compliance. And then, as with a lot of quality improvement projects, we did education with all the key players, because once we identified what's your role, we had to teach them. And Grace did a great job, and a lot of reinforcement on phone calls and one-on-one conversations of really clarifying what everyone's role was. And then we did a lot of focused work on increasing the accountability of our external suppliers. So we established quarterly meetings with regional leadership, weekly meetings with local managers of specific sites, And that really fostered just an open dialogue of conversation that to this day, we're still continuing in those. And if there's any of the suppliers on the line that might be watching this, that was one of the most positive impacts of this this program that still continues. And then we're going to go in the real details of how we centralized all the processing of paperwork. And all of you guys know, I don't know for sure in other states, but like in the state of Illinois for public aid eval, it's mandated that it has to be written in paper. As much as we try to do things electronically in this day and age, you still have to have the patient sign the 12th page. And a lot of things are still, printed out and scanned and sent over to the outside suppliers. So there's a lot of shuffling of paper and forms. And we really, rather than having it person dependent, we centralize that whole workflow. And that'll be a great takeaway for those of you who might be looking for small pearls of wisdom and improvement that you might be able to take back to your own organizations to help optimize succession planning for your staff, as well as facilitation of workflow. So I'm going to have Grace kind of talk through the different stakeholders a little bit more in detail, and then we're going to share a fun little chart with you guys. So
I love that chart. But yeah, so here we can see a list of our key stakeholders. So again, the physician is quite centrally key as they refer the patient over to our wheelchair seating center, and then also they start off the first of many documentation, but by them seeing what's called the face-to-face with the patient and kind of just documenting again the patient's medical needs and requirements, and also their limitations if they don't have the wheelchair. So this one kind of really, everything is a little bit of a starting point with that physician referral and the physician documentation. And then also just due to the EMR improvements, and then also kind of just again streamlining all of the ways that we scheduled a patient, we are actually able to leverage our centralized scheduling staff into helping us schedule at least the initial outpatient evaluations for our patients. So again, teaching them kind of just the standard processing, and then also again the standard verbiage needed to kind of walk through and schedule these patients. But still, again, it was really key to kind of leverage again as many resources that we have in the hospital as possible. And then here finally, or thirdly, I should say, we have the wheelchair support staff. So my role as the business support manager was also here in that support staff, but they're really, all of that administrative work has to be done by somebody, and kind of just by offloading it from the physical therapist in the wheelchair seating center or from the vendors and such, we're really able to kind of take a little bit more ownership of that. And then by doing so, also really making sure that everything was actually in line accurately. And then unfortunately, all I's dotted, all T's crossed, because sometimes those were forgotten. But really the support staff was really kind of making sure we kind of guided again the whole entire process from start to finish. And then also kind of being that key link to the patient and letting them know, again, we are advocating for them. They'd be able to reach out to us with any questions or concerns or anything at all whatsoever. And we'd be able to kind of, again, advocate and facilitate any discussions needed, either with the physician or with the vendor or with other parties as needed. Again, also, we started to leverage our financial clearance staff and department here over in our hospital. So again, just making sure that we're able to, by streamlining again our process and really reducing down that time frame of delivery, then we were able to kind of again adhere to the regulatory requirements for that physician plan of care, so that our clinicians were able to operate with those referrals. And then also critically, we do have our therapists trained in occupational, or trained in wheelchair and seating techniques and experience. And then also with our medical records, again, with those unfortunate 12-page IDPH forms for the letter of medical necessity for public health, those definitely need to get inserted into the medical records. So we again leveraged our different departments here in our favor. And then also, again, we have the supplier and vendor who works with us. They were the ones providing the assistive technology professional to work in collaboration with the patient and the therapist, and also to build and manufacture the wheelchair. And then also, again, we definitely have our patient here as well as a key stakeholder that we have to keep as paramount of importance throughout the entire process.
So I don't know, I'm going to pose the question if anybody's ever heard of a swim lane. This diagram, and I'm actually going to bounce back and forth. It's actually 2 pages long, so it wasn't actually able to fit on one page. And we ended up finding a large, 11 by 17 printer. And so it's like on the wall in our department. And I know it's really, really small to see, but I think it's really important from a visual perspective, and I'm not going to read through every single box for everyone to see, but all of the key stakeholders that Grace had been mentioning are on the far left side. And then you can kind of see, so this is where the process starts, and you can, if you follow the swim lanes and the arrows, you can see when each individual stakeholder comes in and out of the process. So I'll just use the physician as an example. They put in the initial referral, document the mobility device visit, then it goes to the scheduler. They're not coming back into the process until the letter of medical necessity needs to be signed. And then if I look to the very end, if, depending on the time frame that had passed, being able to re-enter orders for the patient to actually come back for that definitive fitting. So that's just one example. So if we went down all of these, and Grace made a really good point, for those of you that are on the line, I know almost everyone probably works in a complex seating environment or does complex seating in your individual hospital setting. There's some key players in here that I don't think are typically brought forward in traditional frameworks for the workflow. To highlight the call center, our centralized scheduler, or the financial clearance department, even though we as a hospital are not submitting specifically to the insurance, that's what the supplier is, but we still want to think about the patient coming for the appointment. It's a therapy plan of care. So we want to make sure that they have active visits that are approved to be able to come back for that fitting, or if they need to come for a power wheelchair trial or a power assist trial before that definitive order is complete, that all of those barriers are removed so that you're not having a time lag waiting for that insurance approval for the actual physical therapy sessions or occupational therapy sessions that are taking place. The other thing that not a lot of times is popping up is medical records. So, we found this as a big opportunity for us. We got some feedback that, when we were inter-office mailing or inter-office couriering the documents to go to the physicians, unfortunately, a couple of them went missing. And if it was a handwritten document, it was gone. And so as part of our workflow, once the therapist had completed the documentation, we partnered with our medical records department that they would pick it up at 7 in the morning when they get in. They would return it by, the mid-afternoon. At that point in time, the first version was already scanned into the medical record. So if anything got lost in that handwritten note, even though in this day and age, we don't want to have handwritten notes, some of our therapists were kind of old school. They still wanted to do it handwritten. We didn't have that as lost. And so we could always re-pull it if it needed to be referenced. But just by having that standardized workflow, it really prevented a lot of things from getting mishapped as well. And then we would have a second scanning, and I'm sure a number of you are balancing the limited work resource that you may have in your department. Like, it's not uncommon for seating centers, even in the Chicagoland area over the last 5 years. Unfortunately, a number of them have gone out of business just because it's unsustainable because of the workload that's associated with each individual order. So, we had the support. Shirley Ryan is vested in keeping a seating center, but we really had to optimize what are other departments within the hospital that could help us with some of these, whether it's the centralized scheduling, medical records, financial clearance, because that was really some of their areas of expertise. And if we could partner with them to help us with some of the workload, then that just enabled us to focus on more of maybe the relay of the prescription that was coming back from the supplier, or rounding twice a day. And we'll talk a little bit about that in a couple minutes as to how we optimize that. So we'll continue on. Any questions on the swim lanes? I would have loved to see the show of hands of who's seen them. I think before COVID, every tour that came through saw these workflows, and for the residents that we're training and other new clinicians, I think it's a good eye-opening, because a lot of times people just think, oh, I need a wheelchair, talk to the doctor, get a complex, you need a power chair, go get a power chair. And then they really see all of these steps that take place, and it visually and I think intuitively gives them a solid clarification of the multi-step process that has to take place from beginning to end to eventually see that patient wheeling or driving away in their new wheelchair to help foster their independence. Any questions? All right, we'll continue on. You guys are taking it all in. So that's our swim lanes. If we have some time at the end, we'll be sure to go through it. So I'm going to actually have Grace talk a little bit about our request list and how that came to be, because it wasn't existing.
So originally, with requests to schedule at least definitely an inpatient, sometimes those were literally just an email to one singular person. Hey, I need to have this patient seen for a wheelchair. Obviously, that is not sustainable at all whatsoever. So kind of leading into that, we created a centralized inbox so that therapists would be able to email in and send in requests. And so then that way, now it's not stuck in somebody's personal inbox, and especially if they're on vacation or out sick or not sure how to address the inquiry, then this way it kind of has that accountability, and we're able to use that inbox and have multiple people kind of triaging and working through all those requests. But obviously emails directly, even if it is into a centralized inbox, is still not efficient. So what we did as part of the EMR revisions was create electronic Cerner power orders that the physician would place. And we actually purposely made it a set so that when the physician was actually seeing a patient for their mobility device visit or their face-to-face visit to do that documentation on the physician end that they need to have a wheelchair, they would also place a set of electronic orders and automatically have both the documentation embedded into or prompting automatic embedation into their medical notes, and then also place electronic orders that would flow into this request list. So by looking at this request list, you'd be able to have either your inpatient staff or your outpatient scheduling and or the wheelchair support seating center staff able to kind of work through this request list and see, hey, I've got patient A, they've had their order placed on X date, let's go in order and let's get them scheduled as we check through all the requirements needed for scheduling an appointment. So in this particular case, it's extremely efficient. And then also we were able to really leverage this with the support staff to, again, kind of really have now a task delegated. It's like, okay, work in the morning on this request list, just go ahead and schedule everybody here as much as you can, leave voicemails and such like that. And then also really leveraging also the commenting system as well, at least through Cerner, we were able to kind of put that track in there of like, okay, this patient's been contacted once, twice, 3 times. And then from there, be able to message a physician and say, hey, this particular patient is not, being, I haven't been able to contact this patient yet, just in case they were wondering about a status, and kind of, again, really updating them on how the referral and the process is going, at least in terms of scheduling the information. So again, with this request list, we also split it specifically between inpatient and outpatient scheduling, because again, with inpatient scheduling, we really want to make sure we maximize the amount of time that the patient is staying in-house. And then again, really scheduling just based on their diagnoses and current functional levels, and just again, being able to make sure that we're getting things in line in preparation for their discharge back to home or discharge to another level of care.
Well, yeah, and so there's just a couple of questions. I'm just going to pause for a minute. So the question is, if you're able to share the swim lanes, I will share my email in the chat, and if you would like a copy of the swim lanes, I can definitely share that PDF. And then and then another person has a question about the Cerner task list appears as a separate list from the general OT or PT eval treatment task list. So yes, that is exactly right. And so this is where when we partnered with other departments, we learned that in the call center, they work off of just request lists. And so one clarification, as Grace was mentioning, I know we didn't have a screenshot of the inpatient and outpatient because I know it's just a list and you can't see everything. That was one of the things that we learned from when we talked with them. They were like, oh, we just look off this list. And we were like, well, why can't we have this as an inpatient list? So yes, we were able to customize a list, and that's totally separate from the general evaluation and treat order. So one of the additional things to consider, and we don't go into this right now. So since the complex seating, it's technically a specialty order within our organization, just like you would have for casting, I guess it's casting and seating, and then I think eSTEM specifically within our organization. So the physician has to clear them or make that referral. So yeah, and that was super helpful because like Grace had mentioned, it literally was like random, like there were all these emails just everywhere. And we were like, we need to make it systematic. And that's a common thread just to kind of resonate for everybody. And just to kind of reiterate, when we moved into our new building, our census increased from about 160 patients to now we're at to 220 patients. So the thing that our goal with a lot of these changes was how could we continue to grow the census and keep consistency of the workflow. And that's where we had to tap into like what features might have existed in our EMR. There's one other chat, I'm just going to read it. So the question was, once the seating order set was created in Cerner, what is it relatively easy to set up your specific task list? We currently have a specific order set in Cerner for our adaptive equipment, but it doesn't appear on a separate list. So yeah, so we actually have it set up in Cerner. It's like, we just had to come up with how we were going to name it. So like one was like inpatient, and one was like outpatient. So that was something that I would probably recommend you need to work with your Cerner IS representative to see how they could be creative. We might be able to, if you want to email me, I might be able to share those little bit of specifics, but it's no different as within our organization. There's a lot of other specialties. So we have like lab referrals to like the vestibular therapist or the technology center. So probably similar to how you have it for adaptive equipment. But I think one thing you might be referencing here, the physician orders have to be driven to that specific area to be populated on the list. So that might be part of the gap that's missing, but great questions. I can see there's some Cerner people out there. Wonderful. So we'll keep moving forward to the next thing. And this is something that we adapted from our outpatient colleagues. So in the outpatient department, as we were kind of learning how they operationalize some of their workflows, they reported to us that, if you go for a PT eval, the patient gets a sheet, and that's what they take to when they're leaving, and the therapist writes in it, I want to see you 2 times a week and for 4 weeks. And that's what they said they put forward, and that's how they actually end up scheduling their patients. So we modified this and it became known as just the yellow tracking form. And this is kind of what facilitated our workflow, one from the initial point of scheduling the initial evaluation. And I know everything's a little bit hard to read, but it really, it helps us to know who the supplier was, who the therapist is. If for the inpatients, were there specific precautions, like if they were on a ventilator, did they need a VAD? Did they have a sitting tolerance? Who the physician was? It was also a good tool as we were training new staff in the department, just to make sure everybody was jogging their memory. Did I get the mobility device visit? Did I send the paperwork to the supplier? And then it kind of ended up following the patient all the way through. After the evaluation, what's that recommendation going to be? Do I need to schedule another appointment for a wheelchair trial, or are they going to come back for a molding? And what we had been reported to before the changes had occurred, unfortunately, patients kind of were getting lost. It was like they were going to try and call and get rescheduled. Maybe they were going to come in a couple of weeks, and then before you know it, a couple months passed and they never came back for the equipment trial. And then at the very bottom, you can see that we had our support staff and the therapist kind of working together of when did we get the information from the eval, from the ATP with regards to the specs for the actual equipment that was going to be ordered. And then when did the therapist complete their documentation? And then eventually when was the fitting scheduled and completed? And then once this was done, then we knew that the whole cycle of the patient experience was completed. And along with this, and I'm just going to talk through it. Another parameter that we went through was establishing expectations for the ATPs as well as the therapists. So we looked at the policies first from our therapists. Across the whole system of care, it was a requirement that all evaluations should be completed within 24 to 48 hours of seeing the patient. We knew that things weren't happening in that context, so we needed to tighten that up. And this documentation helped facilitate it needed to be done. The other thing, and that was important from a regulatory perspective, we had also done an audit with our legal department and compliance, that was an area that, you know, things were just kind of being left open of documentation or modified of historical information, and that was a vulnerability for us from a regulatory perspective. So when we made some of the changes to the Cerner evaluation, and that's kind of beyond the scope of this, we probably could have a whole talk on Cerner changes with all the interests of Cerner here, but we actually modified our documentation so that you could always close out the first time you see the patient and finish the eval. And then there were components that could be repeated in follow-up treatment sessions that you could still make the recommendations for the specific components for the equipment. And then they would just be paired together in a packet. And that took some education with the suppliers as well. But the other thing, and I know I wanted to loop back to this little date, the supplier form received. So we really made the expectation with the suppliers that we needed those measurements within 24 hours of the appointment or at the end of the appointment. And we had found out that, you know, though we partnered with our suppliers, sometimes the therapists were waiting 2, 3, sometimes 4 weeks to get those measurements to be able to finish their documentation. And that really wasn't helping to ensure accuracy of the information and to really finalize those equipment orders. So that was a critical thing. I don't know if you want to add anything. I don't know how we picked yellow. I think it was just the color that we found in the closet. And if you want to share anything else, Grace?
I don't think there's anything else, but kind of, again, just using this yellow tracking form really to follow through. And again, just being able to, this also sometime would assist if, and potentially if we had staffing complications, potentially like a therapist was out sick, at least this way would kind of give a little bit of handover, just be able to really at least maintain that patient appointment and really still be able to kind of service the patient through everything.
Yeah, the other thing that was used for this, and I know we're talking a lot about Cerner, believe it or not, there was not a way to pull a formal list from Cerner of who had an active order. So when we took over the department, there was not a master list. And so that was one of the major undertakings that we did. And here's another really tiny picture. I can't really zoom in too much, maybe a little bit. Let me try. Not too much, it just kind of magnified it. But with this, and there's kind of 3 layers, this is what we used as an initial data point to start the process. And then we had a master Excel spreadsheet of who had an active order. And this is ultimately what we utilize to get our current data of the changes. And that's what we'll share with the final results. And if you read the abstract where we got them from. But this is how we were able to see, you know, what inpatients had a wheelchair order, when are they discharging, when do I need to get the loaner chair, all of those specifics, because prior to these standardization, that process was also at the mercy of the primary therapist, emailing a person in the seating center, Joe Smith is leaving on Friday, can you get the loaner chair? And it was just a lot of back and forth. So we had to standardize, you know, getting the discharge dates, updating the discharge dates. And as you guys know, if you're working inpatient, it changes by the day, it changes by the second. The person could be, going to be leaving 3 weeks from now, and then we find out that their insurance cut them off and they need to leave in 2 days. So all of those types of things. And then we also, I will say this is probably a learning for us. There's a lot of different columns. So just so you can kind of see, here's like one category, here's the second, and here's the third. So we learned that likely it would have been better not to categorize so many things. As you can see in some of these examples, there were openings. We really at some point had to triage what were we feasibly able to collect, and it really ended up being those critical things of the patient, their date of birth, the supplier, the discharge date, and then when was the initial val sent, and then finally when was the definitive delivery made. And part of that was a bandwidth for us of what we could data enter. So, and I'll have to call out Grace, she's a little Excel wizard. And Dave Brewington, I do want to recognize him. His major contributions to the project and other QI projects within the organization has been being able to utilize Excel for different reporting, and then being able to manipulate it to do some analyses for us to be able to kind of benchmark if we are making any changes. So anything else to add, Grace?
Kind of again, reiterating with all the different columns with the Excel spreadsheet. One of the things that we were also hoping to accomplish with the spreadsheet and our data entry was kind of also, again, making sure that we had accountability with our suppliers and kind of just speccing out, okay, this is a reportable, the patients who have an order, it's been 30 days since their evaluation, what's the status on these? And then also kind of just scaling from there, 60 days, 90 days, and then anybody plus 90 days, we really need to figure out what's happening over here. But unfortunately, again, that one had to go by the wayside, unfortunately, with bandwidth, and then also just unfortunately with the capability of Cerner, we weren't really able to pull out again those reports either. But ideally, maybe potentially in the future, / if we ever do get a new software, which is something we did explore, but at least Excel was able to accomplish what we needed. And again, I would pretty much daily be, if not every single second, inside the spreadsheet, kind of constantly changing, updating, and pulling information from here.
Yeah, this really became our master workflow. So I don't want to think that we're trying to advertise Cerner. That just is the platform that we use. But if any of you are thinking about starting a complex seating center, one of the key things in any EMR is what is going to be extractable to your data warehouse. And so our current documentation had nothing that extracted from the documentation for the seating area to a data warehouse. And so if that happened, if you're able to foreshadow to be able to make that change, then a lot of this information would be able to source through to an actual exportable data tool such as Excel or another format to be able to do that. We did not have that capacity, so we were making do with what was within our reach. But if you're starting from scratch, that is definitely something that you would want to consider. Our documents were too old to be able to do a full revamp of the entire framework of all of them to extract that. And key things that we did make progress on as far as like discharge dates, correlations, that was all coming from other documentation from some of our colleagues, such as the case managers that were inputting that to information that was going to the admitting department. So another reinforcement of trying to think outside the box of what other platforms or reporting might other departments be tapping into. Obviously, admitting wanted it for bed management to get that new admission to come. We needed it for the opposite to know when is that person leaving, and then we need to work backwards from that discharge date. So that would just be another tidbit of considerations if you're starting or if you are taking on the opportunity to revise your current workflow. All right, so here's an example of the letter of medical necessity. We actually adopt it for some of our non-complex equipment, and we call it the equipment progress note. That was some feedback that we got from a Medicare intermediary a number of years ago, so it didn't get fully adopted, but just so you guys know that that name may be going around. And prior to some of the changes, we were not able to print from Cerner into a PDF format. So we used probably more paper than any department, because every single letter that was being written, that, you know, when you type it out in Cerner, it was like 16 to 20 pages long. We were printing out and then going to the computer and scanning it, and then having to prior to some of the changes, we were actually faxing them to the outside suppliers. And then when we got reports that they couldn't read it, and things of that nature. So we actually worked with our compliance officer and got permission that they were comfortable with us sending everything via secure email. And this was our way of then being able to have a record. So we would carbon copy our centralized email on every document that was sent out. And we've archived that now for about 5 years. We're on the shared drive. Nobody said that we've taken too much space, and we'll keep moving forward with that. But this was actually a really monumental for our department to adopt this. And this was actually being utilized only in medical records throughout the entire hospital. So we caught wind as we were collaborating with the medical record manager for scanning our papers. And she was like, oh, do you know anything about XR printing? I was like, what's XR printing? She's like, oh, that's where you can print from Cerner to PDF. And so we adopted this entire workflow. And so there was a method that you would view the note in Cerner and then be able to print to PDF. And then that was how we were ended up sending. And that minimized the printing, the scanning, and then we had a record of everything that was being sent. And then if you look into a little bit more detail, some of the other features that we were able to integrate into this is that it would auto-populate a customized face sheet that had all the requirements that all of the outside suppliers would want. And then it had the actual letter of medical necessity. And in some contexts, if you wanted to, so like when we were scheduling an evaluation, we would send the face sheet and the physician note that would include the mobility device visit. So we all know that there's timestamps that are sensitive to the mobility device visit. So we wanted to get that to the supplier. We didn't want to have the patient coming for their evaluation and then realizing they never did a mobility device visit. And then we're waiting, and then the letter of medical necessity is expiring, and that sort of thing. So that was a super, super big accomplishment. And other departments since this time have really tried to be like, wow, that's a really pretty PDF and very clear to read. And they've started to adopt it as well. And then along with, anything to add, Grace?
Nothing there, but besides, it's a lifesaver.
Yeah. And I want to be sensitive to our time. I know we have a few more slides and we only have about 10 minutes left, but hand in hand with, you know, what would we PDF print was creating a report. So this is the one thing that we could get from our EMR, and that was being able to determine if the therapist had notated, and this was a modification that we were able to do, they would click one little icon that said, yes, this equipment order is complete. And that populated onto an existing report, because prior to that, it had every note that had ever been written related to a wheelchair. And that was too much information for someone to be scanning through. So we came up with this fancy thing, and that's what's in green right here. And it is notated in computer language as a hashtag. So a hashtag meant that the therapist had declared that the order was complete. And Grace has probably processed thousands of these through this report. So I'll let her add a few more things.
Yeah, so a little bit more, just again, this would be especially useful in those cases where you have a patient and you're not able to make final recommendations in that very first evaluation. Let's say they just need more time to make their more decisions. They need to complete wheelchair trials. So again, with the particular report, I would be stuck skimming every single wheelchair documentation. But with this, then the therapist would be able to indicate, yes, final recommendations are complete. And again, really just speed up workflow and efficiency for me in order to process these and send these off to the supplier as soon as possible. So again, also with this particular report, we were able to program it so that it would spit out of our printer at 7 a.m. in the morning. So it was there ready to go for us at the very beginning of the day, every single day, including weekends, but we didn't actually process those. But yes, just being able to at least, again, leverage the reports and capabilities available to us. And again, really just efficientize everything.
Yeah, the other thing that's here, if by chance a physician would have missed signing something, we would then be able to notate it and kind of do a gentle nudge, either resending it or sending a message in Cerner to the physician, can you please sign this document? So that was kind of a note to us as well, if the order was complete. And then these are some documents that you guys are very familiar with, a critical part of the process, which is our physician orders. So some of these came from outside secure emails from the outside suppliers. Some of them would have been sent to our centralized inbox, a whole variety of methods. And prior to when we started making changes to the department, these documents were inter-office mailed in a manila envelope throughout the hospital, and the central supply mailman would deliver them. And sometimes it would take a couple weeks for things to come back. So we started rounding with our physician admin supports, and we put all of these documents in a red envelope or a red plastic folder. And these, we also educated the physicians to say, anything that comes in this red folder, please sign within 24 hours. And so we partnered with physician practice to create that sense of urgency, and that helped facilitate the turnaround time. And then we also tracked everything that was being sent up, and then when did it return? So if things were missing or physicians were out on vacation, you know, we would always know, has it come back and what do we need to follow up on? And this is just kind of like a shout out again to Grace. Just, we did tally it at one point in time, and I thought it'd be fun factoid. In an 8-month period, we processed about 2,100 documents of these. So a significant amount that did involve some of our DME orders because they kind of function in our department. I know we kind of separated this, but for this specific, it's just a lot of paper shuffling, and to be able to turn that around quickly was pretty powerful. Another form, and I know it's been revised as of late, but at the time of this project, we were still using the Medicare 7-element form. So this was another document that we facilitated turning around, and we worked to having samples. Grace came up with a great idea of having it written in red ink because it has to be handwritten by the physicians, but we would actually have one copy that we would write in red that showed them exactly what needed to be written, and then a blank copy, and then the physician would just rewrite it in their black ink in their own handwriting. And that minimized having a lot of the errors that were coming back because they wrote it wrong or it was missing information. And that would help to facilitate turning these around as well. Other forms you guys are familiar with, the detailed product descriptions. They were shuffling back and forth, another document to keep tracking. And then this screenshot is really how we would cross-check with our admitting department what was, who was going to be discharged. And then as it relates to our Excel spreadsheet, this is how we would compare to our master list. We could filter who had an inpatient order, when was their discharge date, and then we would manually cross-check by name. Did the discharge change? And then along with that, Grace, and here's her little sample email, I'll let her talk about this, of the delivery appointments.
Mm-hmm. So with at least kind of something that we borrowed from the DME, especially with the non-complex wheelchairs, is that at least with Medicare, they don't allow delivery of wheelchairs or mobility equipment unless it's 48 or less hours prior to discharge. So in that sense, we were still partnering with some of our DME suppliers to kind of facilitate that. So we also leverage that to work with those loaner wheelchairs that we were getting from the complex wheelchair company. So by doing the fittings at least 2 days prior to the patient's discharge, we ensured that they had enough time to complete the fitting and be able to make sure everything's comfortable. This also allowed a great opportunity to educate the patient and family on how to actually use the wheelchair, any kind of training. And then also, again, really have something that was, if not exactly custom, at least close to potentially what they may need, and was at least relatively similar to what their definitive wheelchair was like so that they could get used to it and again, really be able to train. So what we would do is kind of daily or weekly, again, scan all of those discharge dates, and then throughout the week daily, I would send these emails as we collaborated with our inpatient managers, just to make sure that, again, we coordinated for all of the inpatients who needed these kinds of equipment delivery appointments, just making sure, again, everything was all set prior to discharge.
All right, we just got the 5-minute warning, so we're going to go into speed mode, and just like if you're watching a video, a little bit faster. So a couple closing print screens, I'll just highlight. Here's an example of our centralized email that's on our shared drive, and just for a pulse of how much volume is going through there, 28,000 emails in 8 months. So a significant volume of work going back and forth with the relays. I kind of compare it to the Grand Central Station. Here's some examples of what that would look like. You know, we would categorize everything by year, by supplier, in case we needed to reference it in the past, or of what had happened. And then the other thing that we partnered with our outside suppliers was to standardize the fitting list. So all of the patients that had their wheelchair ready to go, we would get a list from the outside, and this had existed in some format from one supplier, but not from another. Prior, we would get one individual email sent that would say, you know, fit this chair. And by consolidating in a list, this kind of became a relay that we would update them if we had attempted the appointment, if it had been scheduled, or any other critical information, and then that facilitated the supplier knowing when to have the chair there and ready and fabricated and move forward. So I know I mentioned some of the timeframes, the key dates. All of our QI changes happened between March 25th, that was opening day of our new hospital, until April 5th, 2018. And then we really looked at our post data from April 6th, 2018, December 2nd, 2019. And I know everybody knows that things just take time, especially pre-pandemic and post-pandemic. This was done on top of our regular roll. And then we did submit the IRB and looked at a retrospective review of 50 patients between 2014 and 2016. And in summary, we're excited to share that we ended up reducing the delivery time by 21.5%, or 34 days. So if any of you are, you work with your patients that are in a wheelchair, that is definitely a significant. Obviously, any change would be positive, but taking over a month off, as you can see the different changes that we described, covered a wide variety of ways. And our goal was really to shave off time wherever we could by improving efficiency. We also included, and you can look at it in the PDF that's available, just kind of some more our data table for the data people out there. If you want to check our numbers, Dave is the best one for the questions for those. He came up with all of these other standard deviations, but all in all, it was a very, very positive change for our patients and the department. We've included a number of references if you want to look into any of those. And then I also included my email, and I'm happy to reach and engage Grace and Dave if there's additional questions. So I think I'm okay to go over for a few minutes. I know we went right up to the end with 1 minute to spare. But we really appreciate everyone's engagement and interest in this topic. I know it's something that we really have been passionate about, and I hope you can take some of these considerations back to your own facilities and in departments and apply them to improve your workflows. Any questions? And I will stop sharing just so you can see us a little bit bigger. It's good to see we had so many people, about 21 people, so that's wonderful. Yeah, Helena, go ahead. I'm gonna see if I can unmute you. I don't know if I have that privilege.
Let me see if I can find it. Why can't I find her? The alphabet is the same for everybody, right? Well, Helena's a code.
I was just gonna share the CE code.
Oh, okay, thank you.
It's A14Y27, and I'll put that in the chat as well.
All right.
Thank you,
Any
Luna.
other questions from others? Well, this has been super exciting to share this. I was looking back, we submitted this abstract in July of 2020. So just very thankful that we could share it with all of you, and we appreciate your interest. So feel free to reach out if you have other questions.
Great presentation. Thank you.
Awesome. Enjoy your day, everyone. And if you're in the Midwest, stay safe with all the snow. Oh, thank you for the swim lanes. Oh, I was just going to look at the chat here. Oh. Yeah, so Amanda, yeah, that was probably one of the most powerful things. I will say our CEO has seen the swim lanes, and it was a great way to really bridge more business perspective with the operations of our workflow. And I would actually advise that for a recommendation for any project that you're going through. We actually made that on Visio. So if you're just looking for the platform as to how to help organize that, one of our IS colleagues helped mentor us with the use of the Visio to make the swim lanes too. Any other questions? Okay, so yeah, they're just gonna, if you want to just make sure you just complete your survey. Any other questions? We have a few minutes for the specific order sets for Cerner. All right. Does anyone else need to be unmuted for a question? I think we just have about 4 of us left.
There's no other questions in the chat box.
All right. Well, everybody have a wonderful day. Be safe. And thank you again for your time today.
Thank you so much.